I work in Atlanta. I couldn't be here today if it wasn't for my partners of 26 years now, Ronald Goldstein and David Garber. They've really allowed me to do the things that I'm most passionate about, with a great team to work with, and all the material that you see, anything I've ever presented or published couldn't have been done without their support, and of course, I thank them for allowing me to be able to do that. One of the things that has been really special to me is my involvement with Dental XP, and that's been a community. And when I say community, completely different than just an educational site, but a community because it allows us to actually do things that I think is unprecedented. And let me explain what I mean by that. Much of what you're going to be seeing today has been developed through what I would call crowdsourced learning. It's an empowering way to learn. And let me explain what that means. Many of the people you're going to see on the podium today, and many of the people sitting in the audience today, were really involved in developing, in particular, these two protocols that were cutting edge. Partial extraction therapy was actually developed on Dental XP's forum. The term, the name that's taken off has now been published. And of course, osseodensification, when it was first introduced, was really something that on Dental XP, a lot of the interaction was what led to the development of some of the ways that this incredible technology is utilized. And I have to thank so many of them. Howie, of course, who's going to be presenting later, Jonathan, Jorge, Chuck, Juan Alberto, Jose, Isaac, Armando, Richard, and so many more. Gregory, it's been fantastic to be able to work closely with them. Ehab, who's a young, fantastic surgeon as well, and all of them have participated. And what do I mean by participation? This is just some of the posts and some of the discussions that were taken from what amounts to about 200 or so osseodensification posts on the Dental XP forum. Think about the data. Think about the amount of information that could be cultivated through being able to interact with colleagues from around the world on a particular discipline that is new. Howie and I have been working on some of our articles, and Howie knows all too well now that it takes about 3 years, 4 years to get a publication out. But yet on Dental XP, it's something that's immediately out there, and now we're learning from each other. It's not one group publishing somewhere in the world, but it's actually a group of clinicians who are sharing ideas. So the real idea behind this concept, this crowdsourced learning, is actually much improved than what we used to do, is wait for periodicals to come out, waiting for journals. So this was an article I published with colleagues of mine in Japan, Tom Ishikawa, and it was really, at that time, a very interesting article for me to get involved with these gentlemen, because we were looking at complex, three-dimensional bone and soft tissue defects, and how do we actually manage them? How do we end up optimizing the aesthetic results in compromised cases when we're going to be using multiple implants? And maybe the most complex and most challenging of all situations. And in the article we published, this was back in 2010, we talked about how do we manage, how do we diagnose, how do we understand the complexity of deficiencies like this, and how do we manage it in 3 dimensions? And we talked about the need for the disciplines of bone and soft tissue augmentation. We cannot do this just by one singular approach. So even if you're great with bone augmentation, that's wonderful, but without knowing how to manage flaps and doing second stage uncoverings and adding tissue, the case inevitably is not going to end up as well as you'd like it. So when we want to end up with a result like this, it takes our ability to plan it from inception. And that's the difference. And this article, already now 7 years old, but really it became the foundation for me on how I look at my cases. How do we get here when we started with such a deficiency? Some of the concepts that we've been talking about for many years is depending upon the remaining bone, whether it's a horizontal or vertical defect, sometimes a combination of both, some of the concepts that have been established over the years has been the concepts related to distraction osteogenesis, guided bone regeneration, ridge splitting, and interpositional grafts. When the bone is very severely deficient, as you'd say, you only have 4 to 7 millimeters of remaining bone, we have to consider onlay style grafts where we are going to build the bone up in a three-dimensional way, whether it's horizontal and vertical or vertical by itself. And we really utilize appositional onlays, bone blocks. And today, how about the concept of BMP2, bone morphogenic proteins, and using some form of titanium mesh to establish the space for regeneration. This is a very exciting time in dentistry and regenerative dentistry because we can now, with these concepts and surgical concepts, we can add growth factors, whether it's BMP2 or whether it's PRF or sources of blood-borne bioactive materials. What we did publish in that article was that there were several common denominators for success. I'd say this is sort of the holy grail for successful surgery for our group and our colleagues in Japan when we wrote it. And really, it comes down to flap design, space management, access to regenerative cells, growth factors, bone graft selection, occlusive membranes, and of course, tension-free closure. So despite the technology, we still have to do the surgery. We still have to perform the surgery and make sure we understand how to develop the site in a very, very ideal manner. So if we take a look at a case where we start in the anterior region, and I don't know if Mike remembers this case, but believe it or not, I saw this case and sent it down to Mike several years ago. He may or may not remember it, but this young man came to see me and David Garber. It was a few weeks after extraction. He has a full complement of teeth. He was 28 years old, young man. He was engaged to get married. He became, believe it or not, one of the youngest principals of a school in Atlanta. Very, very nice young man. Went in to get a tooth extracted that had resorption. He came in about 2 weeks later. Somebody told him to come see us. And this is what was coming out of the extraction area. There was suppuration, infection, discomfort. He complained of pain for quite a while after the surgery. And then large spicules of dead necrotic bone came out of the site. The history of the extraction was that a piezo or ultrasonic tool was utilized to remove the tooth that he remembers. And that this happened maybe because of iatrogenic causes. So it's always hard to deal with a young gentleman. Really, it's painstaking for us because we understand that over time, after we remove all those spicules, place them on antibiotics, the collapse of this ridge was dramatic. It was significant, and the bone loss was not only interproximally, it was also on the facial and palatal aspects. So we're dealing now with a young man with a full complement of teeth who simply came in, was told that he was going to have a fairly routine procedure to extract the central incisor and replace it with an implant. All of a sudden, a few months later, he ends up with a deficiency like this. You can see that from the 3D scan, tremendous amounts of bone loss. He continues to heal, and we understand, again, that we're going to have to rebuild the site in 3D. And really at this time, several years ago, I actually wanted to get an idea of how would you manage a case like this? What would you look at? We had issues with the adjacent teeth being somewhat mobile from the trauma and loss of bone. So we stabilized them. We did occlusal adjustment. And this is actually a case I'm sure Chuck remembers and some of my colleagues from the Dental XP Forum, because I published it here. And I actually asked for information and ideas. I think Howie made a suggestion of what kind of flap design he suggests for this case. And I actually utilized some of those ideas to treat this case. So this patient benefited from our interaction on the Dental XP Forum. So I appreciate that. One of the first things we did is we augmented the area utilizing soft tissue taken from the tuberosity to get us some density of tissue and keratinized gingiva to manage the case later on with bone. So soft tissue had to be built first. There was a lack of keratinized gingiva. We do that first and we allow that to heal. It also allows us to provide the patient with a temporary prosthesis that looks a little bit nicer. He can smile a little bit more. And we came back a few months later and we did a little laser plasty of the area, conditioning that tissue and waiting to see what happens just from stabilizing those adjacent teeth. Is this going to be a singular area we're working on, or is this going to involve the adjacent teeth? This was a big issue. And actually one of the questions, believe it or not, Mike, I don't know if you remember, but we talked about it on the phone. I sent them down to you. And Mike said, the best thing you can do, Maurice, is stabilize those teeth, and let's wait and see how things go. And I really appreciate that kind of interaction, because it really helped this gentleman. He went to several other people who told him immediately he's going to lose those other teeth. Mike suggested we wait and see how things develop and make sure that we're able to deal with the soft tissue issue first. Of course, utilizing a lot of the things that I learned over the years from people like Mike and many, many others and Howie, we were able to take some bone from the ramus, and we are going to now utilize some techniques, and I learned even more so just recently being in Brazil with Howie on how he shapes these blocks, utilizing them in such a way to be able to use them as a space maintainer in many ways, as a little thin plate to support the bone graft behind it. So we're utilizing piezoelectric technology. Flap is made. We can see that we've extended that flap. We end up exposing the area and being able to graft this area. You can see the defect is quite significant vertically, about 10 millimeters from the future interproximal height of bone, where we want it for soft tissue support. And we're going to do bone blocks on both sides, sort of a Curie technique where you're using smaller blocks, shaping them and placing one on the buccal aspect as well as one that's going to support the palatal aspect of this defect. And this is a case, as I said earlier, that's obviously quite challenging. So we're floating the blocks, creating a space so in between these blocks we're going to place bone and BMP2. So we're going to really try everything we can to try to regain the bone back into this very severe type 3 defect. So here is the blocks in place. They've been stabilized with fixation screws. Then interpositionally between the blocks, we're going to add bone and a growth factor, bone morphogenic proteins. Of course, extending the flap to be able to gain primary closure, tension-free, and to maintain that tension-free closure is so critical. And here we can see this now after a month or so. The area is healing quite well. We don't have any wound dehiscence or issues with the soft tissue on closure, and we wait. And typically with these types of cases, I like to wait a period of about 4 to 6 months. In this case, we waited 6 months. Patient came back in. You can see how nicely this has been regenerated both on the palatal aspect as well as the buccal aspect, and we're able to place our implant really surrounded by new bone. We take a look at this at the time of uncovering. We're able now to place our implant completely surrounded by bone, and then our ability then to consider the next phase. We added acellular dermal matrix to add an additional thickness of tissue, so we're already considering not only that the bone has been built and the implant's been placed, but also considering the soft tissue. Whenever we have an opportunity to thicken the soft tissue, we do so. We attach that dermal tissue to the labial flap and then utilize PTFE sutures for advancement of the flap and closure. So now again, we go through the procedure of tension-free closure, complete submerged healing environments, which I would suggest in these types of very, very advanced cases. And we can get an idea of how this site has been developed, from the blocks and the screws that were put in to support the bone, and now the implants being placed. And we can see that we've been able to really regenerate a site that was quite severe. It's not ideal, certainly not perfect. One of the challenges you're always going to have in these areas is the interproximal bone. When we have a zero-wall defect and exposed root surface, I think our limitations, and this is something again that I learned from Mike, he would tell me your limitation with vertical augmentation is the adjacent teeth. Where's the bone on the adjacent teeth? So when we have a zero-wall defect on an adjacent tooth, we have to limit our expectations and our patient's expectations. So one of the ideas behind this is really to be able to go in there and structure the tissue as best we can. The option all along was to potentially use limited orthodontic therapy to bring down the interproximal bone and bring down the papillas for this young man. And we had spoken to him about that. But considering where the defect started on day 0, considering what his cone beam CT looked at on day 0, and seeing where we've taken him over a period of about 1.5 years, to me, from a bone standpoint, a tissue standpoint, was impressive. David Garber then went ahead, we exposed the implant, he made a temporary restoration, and we discussed with the patient whether or not he wanted to pursue extrusion of the lateral incisor, maybe to bring down the papilla. He told us after 1.5 years that he's getting married and he needs a break from us. He said, I really appreciate it. I don't have this ridiculous flipper in my mouth, Maurice, and I'm going to get married. And I said, listen, if your wife likes you the way that tooth looks, that's fine with us. But when you're ready for another wife, come back in, we'll fix that tooth and make it better. So we're all here talking about, and I'm sure yesterday I missed most of the morning and some parts of the afternoon, but I know obviously we saw some amazing presentations because I know those gentlemen very, very well. And osseodensification, what we can do with these incredible burrs, and really as we're already going to be talked about and will be talked about the rest of the day, is how versatile is it, these concepts. And I'm going to just take you through some of the ways that I've incorporated this technology. So number one, I know 3D bone augmentation, soft tissue augmentation is required. Chuck made a point about the aesthetic zone being the whole mouth for me, and maybe that's true now. But really, when we look at how we deal with cases, it may in fact change some of the concepts. This gentleman had a failed implant, it became infected. He came in to see us, and obviously one of the things that we have to discuss is the diagnosis. And the diagnosis here is it's a type 3, it's a vertical defect. And when you've lost bone on the adjacent teeth, on these adjacent teeth, when you look at that interproximal height of bone and the deficiency is so significant, it's very, very limited. No matter what we do to condition these roots, when we have had exposure of the cementum, when we've had bone loss around the teeth and there's no bony walls to be able to support regeneration, very difficult to tell these patients that you can regrow papillas with anything, with any type of predictability. So this is a type 3 defect. We're always going to be limited in terms of interproximal growth, and then we tell the patient some of the options, obviously, to meet to this day is always going to be orthodontics and orthodontic extrusion after we place the implant regenerated to the best of our ability. And we tell them that from inception. One of the great things about the burrs, everybody talks about its ability to have osseodensification by using it in counterclockwise fashion, but also the cutting ability. Now this was a very thin ridge. I wanted to limit the amount of bone grafting that I needed to do and how much exposure of the implant I would have. I already knew I was going to have some of it vertically, so I wanted to limit the labial aspect of this defect. So after utilizing pilot drill, I went ahead and utilized the Densa drills in reverse fashion, trying to gain an expansion of this ridge. And in type 3, type 2 plus bone, type 4 bone, it is outstanding in terms of its ability to accomplish mild to significant expansion of the bone. So here we went ahead, finalized the drilling aspect, and placed a AnyRidge implant from Megagen, and we end up getting excellent initial torque. Really, the head of the implant has to be, for me, placed approximately 3 to 4 millimeters, not more, from where my future restorative margin is. So where the deficiency is vertically, I'm going to use that implant as a tent pole for my regeneration. So here we can see we get excellent initial torque insertion values. One of the nice things about this implant, but also, of course, because we densified the bone utilizing the drills, now I can go ahead and do my bone augmentation. One of the first things you want to do, you can release your flap, make sure you get very, very good tension-free flap dissection. And now we're going to go ahead after doing that, and we're going to perform bone augmentation to try to gain bone over that implant. And we're going to use the iGen membranes, again, using the concept of space maintenance and rigid space maintenance. We're going to use these membranes and attach them to the implants. This is an excellent concept, but also from a technological standpoint, very easy to work with. And I like the micro perforations, and they can be bent and shaped to the defect as you wish. Now we can go ahead and see that with a very thin ridge, we have this little micro fracture that is very evident. We're going to build this out three-dimensionally, create the space for regeneration. And we're going to utilize PRF in this situation. Obviously, this is something many of you know about, a blood-borne bioactive material, ones that I've been using for many years, and I've had an evolution for myself over the past decade or so, in really starting with PRP and now starting to use some of the concepts from Joseph Chacroun. So here we're going to utilize the bone to create a sticky bone complex. I know people talk about the names, but basically being able to get this complex saturated with these growth factors, they become very easy for us to hold on to. They stick together, and you can now adapt them to the area, and then we can stabilize them before we create our space with our mesh. So low speed centrifugation, we have advanced PRF, but it's PRF enriched in white cells, and then of course IPRF, which is the liquid enriched in white cells. And this is something that allows us to get a little bit more in terms of a solid outer shell of that graft. It really stabilizes it very, very nicely. The only challenge is that you need to do 2 blood draws as opposed to 1. So you have to do one intraoperatively to create the IPRF because you only have a certain amount of time to utilize it. So we're going to place the bone, use both types of PRF. We're going to use the fibrin membranes over the top of that bone graft, and then we're going to lay down that titanium mesh, secure it with the screw into the implant, and then we go ahead and start the process of closure. Layered suturing is performed, and I'm going to also utilize a dermal membrane, a pericardium in this case, to make sure that I don't have any rough edges over that, over the titanium mesh with the flap, especially in the mucosa. Some of the problems that I've seen with the mesh is in a mucosal area where you have no attached gingiva or you have thin tissue. There's a tendency for the mesh maybe to become exposed, maybe later on, even not early on, but maybe after several weeks or a couple of months, you may see some exposure in mucosal areas. So I like to augment that as well. Secured it with sutures and perform the advancement of the flap using PTFE sutures. Now, the concepts behind this are very, very interesting. We continue developing these over time. How else do I utilize this very, very interesting set of burrs? One of the ways that I have is in the posterior maxilla, and you're going to see a lot more of this later on in Ziv's lecture. I'm sure he's going to expand on it dramatically. I'm sure Mike touched on it yesterday. But really, this has changed the way that we can address areas in the posterior maxilla where we can do it in a very minimally invasive fashion. How do we replace teeth when we have pneumatization of the sinus and not enough bone? So we're going to use these drills to densify. We're going to do it in reverse cutting mode, and we're going to also utilize it to be able to expand the ridge, but also to gain access to that sinus. And I'm sure you've seen much of this yesterday, so I'm not going to elaborate on it, but obviously the ability for us to save the bone in the osteotomy and to densify that bone allows us to have much better stability, initial stability, and higher initial torque insertion values. Also, of course, with much of what you've seen over the course of the last day or two, if you've been here for the pre-Congress, is the bone to implant contact has been tripled using OD, and also we can look at it from a standard drilling protocol. These things have a spring back effect that's outstanding, and also we can use this for autografting. You can actually take that bone and push it up into the sinus area. So these are all things now you can apply to the strategies that you use. And these were cases that I'm sure that you've seen from Salah, where he expanded ridges and accessed the sinus using this in a multitude of different manners. And being able to do that and do it in an atraumatic fashion, and also to do it with a primary single surgery, utilizing healing abutments the day of. And you can see that the ISQ values are extremely high at initial insertion. Also, the torque insertion, 60 and 50 on these implants at placement. And you can see the little bump in the sinus. So really being able to use it in a very versatile fashion. And I certainly took a lot of that information from Salah and applied that to everyday dental procedures. So whether it's a small bump in the sinus or whether it's just slightly expanding the ridge in the type of bone that would work ideally when it's softer bone, when it's not type 1 bone, very, very dense or fully cortical bone, you can really do a very, very nice job. So this was a patient where we had a very, very narrow area for implant placement in the area of the first molar. Third molar was extracted the same day. Now, obviously a lot of people are talking about today whether or not we can use these teeth as bone graft materials, whether or not we should grind it up and use it as bone graft materials. I think that's a topic that is starting to become somewhat interesting. That's not what I did in this case, but certainly you could. Or you can actually take out the tooth and then use the bone in the surrounding areas utilizing bone chipper drills or bone scrapers. So here you can take a look at it from an occlusal standpoint. We took out the third molar, and in the area of the first molar, we have an extremely narrow ridge. The bone was type 2 to type 1. Very, very, very dense bone, but some cancellous bone behind the cortical bone. And obviously there's a couple of options here. We could take a block and build it up like you've seen earlier. We can use a mesh. There's a lot of different techniques that are available to us, and that's great. But why not take the opportunity and see whether or not expansion utilizing the OD drills will work quite well. So we went ahead and started the process of drilling in counterclockwise fashion. And what was amazing to me is that we got to the point where even when we prepared the site for a 5mm implant, we still had about 1 millimeter of bone on the labial. This was pretty amazing to me. Obviously, it changed my treatment plan. I went into that case telling the patient that we're going to do a bone graft, come back in 4 or 5 months, place your implant. And then I use these drills, and all of a sudden I go from here to here and able to place a 5mm implant. And placing that implant entirely in bone. So here, I'm going ahead, placing the implant into position, torquing it down, very high insertion torques. Typically, if I use OD mode all the way through at a 5mm implant, some of the problems you may have is placing your implant all the way down without having to re-prepare the site. So be aware of that. This is something that I'm still learning, as a matter of fact. So I think we're all going to find little things that we can do better. And I think by sharing this information at forums like this one, or some of the things that we talked about earlier, can only help us, this interaction. So we placed the implant down, torqued it in the last few turns with a hand driver, and you can see that this was very, very high initial torque. Now, remember this, as we go up, it's beyond, we ended up getting this implant down to beyond 50 Newton centimeters. This was before the last turn. And then we place our cover screw, and we went ahead and grafted this area from bone from the extraction site. A fairly routine case. We're going to use a collagen membrane, fibrin, autogenous bone to build out the labial architecture. We're going to stabilize this with pins, all the things that we learned for GBR. We're going to do an advancement of the flap, and this is how it looks, and that's how it looks on the radiograph. So 5mm implant placed in a ridge that started out with about 3.8 millimeters of bone. And we come back later, and I just want to talk about some of the things you may see. If you use these drills in very dense bone, and you use it for expansion, and then you torque at very high initial torque insertion, this was a really interesting finding, because it's not the burrs, it's the utilization of the burrs that had caused what happened here. The implant at exposure, we had very, very good buccolingual augmentation. The implant is osseointegrated, but at the top of the implant where I got maximum expansion with the drills, I had a little bit of crestal bone loss or resorption. So obviously this is something that I have to learn about how much in dense bone I'm going to use the full reverse mode expansion of the bone, using it in OD mode. And I have to learn when and how much I can actually push on that bone. If it's very dense, if you're placing your implants at 50, 60 Newton centimeters, especially with expansion, a couple of things I would tell you to consider. Number one, you may want to only use those burrs in reverse mode on the way up from the bottom of the osteotomy. So you use cutting mode on the way down and reverse mode on the way up. You may want to consider placing the implants slightly subcrestal to make sure that you account for the possibility that you may get a little bit of resorption. This is not unlike things that we've seen with ridge splitting cases. Sometimes I'll place those implants somewhat subcrestally because I do see at the very top of those expansions slight bone loss. So what are we going to do here? Obviously, we can go ahead and tell the patient, looks great, cover it up, send it to the restorative dentist, let them deal with it later. But obviously, there's no infection here. This is not an infected site. This does not have to be detoxified. It simply needs more bone. So we come back, we placed more bone around the top of the implant, placed, in this case, a non-cross-linked drapable collagen barrier, and we close it up and we wait. And I think that that's something, in this case, that I learned from using the burrs. So like I said, people ask me how much I use them. I think really they're fantastic, but I'm showing you some of my scars from battles that I've won and lost. And this was one that I learned from. This patient's going to be fine, but I have to appreciate the fact that with expansion in denser bone, I got to be careful how much I try to use purely the OD setting. Here's another situation where it's changed the way I look at treatment. Patient with 2 periodontally involved failing molars in the posterior region. We're going to attempt to do slight sinus augmentation. I want to see whether or not it's possible. This patient lives from out of town. He's a little bit phobic. How much can we perform in one surgery? Now again, trying to maximize the results of our treatment. If we take a look, we look at it on cone beam CT, you can see that we can kind of place the implants. We have space between the roots. How can I access this area and do so in a minimally invasive fashion, maximizing the bone that's there? Not removing it, but actually utilizing bone plasticity, pushing the bone into the sinus vertically and also expanding the septal bone. First thing is we split the roots, making sure that we take out these roots separately from each other, making it much easier an atraumatic extraction. So the roots are all removed individually, all 6 of those root tips. And now we start the process of placing our implants in the septal bone. Pilot drills are used. And we start the process of expanding, utilizing the Versa drills. And you got to get an idea of how dense that bone is from the cone beam CT, from the Hounsfield units, but also from your pilot drill. When you first go in there with your pilot drill, you get an idea of how dense that bone is. And if it is very dense, then I would limit the expansion in that area to the last drill sequence. So you got to change a little bit. It's not always OD and it's not always cutting mode. Sometimes it's a mixture of both to get a feel for it. And I think that that's something that's going to develop further probably before the next symposium. So here you can see in the septal area, I wanted to get about 4.7 or 5 millimeter implants in this area for the molar sites. We expand that septal area. And now you can take a look. It looks a little bit like a Halloween figure, but you can see the roots here. Now, one of the interesting things is how much resorption should we expect from a ridge like this from the areas of the extraction sites? One of the other things is if you're looking very closely, you'll see that we actually are in contact with the sinus and the schneiderian membrane, and we're able to push that bone apically into this area, which is really one of the real wonderful parts of osseodensification. So as we get to the sinus, the floor of the sinus, something that I'm sure will be talked about later on, we can actually push that bone apically. We can get the implants in with very, very high initial torque values, and we can do so in a very, very minimally invasive fashion. So here the implants are placed. We then use bone graft to surround the sockets around the area, the palatal roots, mesiobuccal roots of those molars. Healing abutments are placed. We utilize fibrin over the top, And then we go ahead and slightly utilize a coronally repositioned flap to gain closure, placing the implants exactly where the middle of those future restorations will be, right through the occlusal table. Other methods where we can use this kind of concept is with sinus decision making. Here's an area where you may consider placing a shorter implant, but if you take a look at this and we want to get in a 10 millimeter implant, are we going to use a conventional sinus approach, a large flap, or can we actually do that and push the bone from the site into the sinus and do that somewhat atraumatically? And you can see we only have about 4.7 millimeters of bone, so I think a short implant to me, I'm still, to tell you the truth, with short implants in the posterior maxilla, I've had a somewhat challenging success rate. I have short-term, very high success rate, and I have long-term, somewhat less successful. I've seen late failures with the shorter implants in the posterior maxilla. That's just my experience. And I'd like to get in implants that are at least 8 millimeters is usually the length that I will limit myself to. So I want to get implants in that I can actually feel comfortable about after loading. So a lot of different ways that we can access the sinus. One of the things that you can do is just simply rely upon these drills. You know the sequence. You're going to see it later on, I'm sure, with the Ziv's presentation. Or you can access it through these types of drills and stops that allow us to access the sinus with a burr that will not cut in the Schneiderian membrane. And these systems are available. I put a stopper on this so it limits how far vertically and apically I can go. And I'm going to use a crestal approach. I have a nice sized ridge. I'm going to access the sinus with a technology, whatever system you use to gain access to the sinus. Once I do that, I can then use water and hydraulics to somewhat lift the Schneiderian membrane. And this is, again, different concepts that use that. Hydraulic lifts of the sinus membrane can be done very nicely, a combination sometimes of using piezo technology as well. And then once I do this, I did this at the 2 millimeter, 2.3 millimeter drill. Now I can use the burrs in OD mode because I've already lifted the Schneiderian membrane. And now I can use bone packing from osseodensification to push the bone from the surrounding walls into that area that was lifted. Now you can do this obviously with the Versa drills completely now. You don't need to do the first step, but this was some of the ways I was using this early on. So I would do the lift first, access the Schneiderian membrane, and then use the drills in OD mode to push bone into the sinus. I will then go ahead and use, when I do crestal lifts now, I'm using just fibrin. I'm not pushing any more bone than I'm getting from OD, more into that sinus. I'm just using fibrin. And I'll pack the fibrin into position. I'll use a wet gauze technique, something I learned from Jorge. So I just push that in there, and you can see very nicely the fibrin is up into that osteotomy. You're looking down on it occlusally, and I can go ahead and place my wide diameter implant into position. That's a 6 millimeter. So I have a 6 by 10 millimeter implant in an area that only had 4.7 millimeters of bone. I get great initial torque insertion, so I can do this as a single stage approach, which is, again, better and more minimally invasive than a lateral approach. We take a look at this where we started, and you can take a look at what we were able to get inside that sinus. It's very, very interesting. And if we look at this over time, I think that's really the advantage. The minimal amounts of vertical lift, I think, can be accomplished very, very dramatically with this type of crestal approach. And this is now looked at about 2 years, almost 2 years, about 18 months to 2 years later. You can see we have maintained that little bump with the implant in position. So I think this is something that we can establish, something that can work, and something that will remain in position. If you see this highlighted PA radiograph, you can see the reddish area where the bone has stayed over the top and apical aspect of the implant. So going from a sloped sinus to one that we've managed vertically through a crestal approach and doing it in a one-stage procedure. What are some of the questions that I continue to ask myself? And I think that all of us should be asking these questions. When should you consider a crestal approach over a lateral approach? It's not always one way, and it's not always the other. It really depends on lots of different information, not something that you can just say, I'm always going to do it this way because it's easier. It's not the case. Number two is what techniques are available for crestal access. I showed you two different techniques, one with a hydraulic lift utilizing a sinus kit, drilling instrument, and then of course you can just simply utilize the Versa concept, which you'll see later in detail, I'm sure, from Ziv's presentation. Is bone grafting a requirement for successful sinus augmentation? The literature tells us no. All we need to do is maintain the space. The periosteum of the sinus is very regenerative. And you've seen studies from Ziv in the past and his team where they showed that with Joseph Chakroun just using PRF in the sinus. There's studies that have been done almost 13 years ago that showed nothing in the sinus. They only allowed for the blood clot. So we really have to think about, do we need any bone? And if we're going to use bone, how much bone and what kind of bone are we going to use? Number four, how much residual crestal bone is required for simultaneous implant placement? How much of that crestal bone could stabilize your implant? That becomes the very, very big aspect of doing it as a single stage or two-stage approach. And how much, realistically, this is a big question, how much can you realistically expect with a crestal approach? Can you get 10 millimeters with a crestal approach? Can you really depend on 3 millimeters? Is it 5? What's the real expected value that you can get from that approach? I'll leave that question to Ziv to answer. So what other concepts are somewhat new and exciting? And this is going to really lead into my dear friend Jorge, who's up next, and I know he's going to talk about this in great detail, and I just want to kind of lead in because I'm using this protocol and these drills. And for those of you that don't know what PET concepts are, it's partial extraction therapies, I think it's a real exciting and different tool. Only a couple of years ago on some main podiums, you wouldn't even see it discussed. This is a process that took a lot of time. When we first published on submerged root technologies, it was 2007 the paper was published. It's 10 years ago. And yet when we first started doing it, people are saying, come on, you can't do that. You can't submerge a vital root. You can't just keep a root underneath the bone, underneath the soft tissue, but you can, and it works extremely well, and it maintains and preserves the bone. This molar had a resorptive defect, had to be removed. If I go ahead and take a look at it, it was somewhat spot ankylosed in the furcal area. And if I try to extract this tooth utilizing conventional methods, the risk of fracture, of damage to the site would have been substantial. This is, again, a patient who's fully dentate. So I want to preserve as much. I don't have a lot of attached gingiva, but I have enough. I want to preserve as much of this as I can in the process. So we planned the case, drill through the root. Now, one of the things that have been very, very interesting for me is Marcus Hertzler's concept of utilizing the roots of the teeth to stabilize your burr. It's very hard and challenging, ladies and gentlemen, for those of you who've had the joy of trying to drill in a septal bone and not have the drill slip into one of the extraction sites or through the labial plate. It's much more stable when you have the roots in position while that burr goes through the tooth. Now, what's amazing about these drills, and again, I have to tell you, cutting mode may be just as impressive as OD mode. This thing cuts right through the tooth. It's amazing, and I can go down to the depth that I want. And I can then go expand that until the point where I've now drilled my osteotomy, completely stabilized using the Versa drills. And now I'm going to take out the remaining parts of the lingual roots, lingual portion of the roots, very atraumatically using root tip forceps, some piezo and periotomes, if you'd like, but being able to do this really with minimal invasiveness. Now I have a question. Do you remove the labial portions of the roots, or do you simply cut them down and leave them in position? This is going to be the big question. It's not what we learned in school. You're going to need new armamentarium, you're going to need new concepts, and it's going to take longer to do, no doubt, and there is a learning curve. This is not where I would do my first case. Pick a relative, somebody who's not paying, pick a bicuspid, you know, don't start with a central incisor on a beauty pageant contestant. That's not how we did anything. We learn on family. That's what we do. The bigger your family, the better clinician you become. So I take Henry's tooth and I cut down the roots to the bone level, just slightly above the bone. In the posterior area, I really prefer to cut the roots down, almost down to the bone level. In the anterior areas, we're still having that discussion, and that's another thing that we have debated on the forum, didn't we? All right? So we look at each other. Should we leave it a millimeter above to keep the connective tissue attachment? How much do we reduce? Typically, I want to reduce these to 1 millimeter in width. They cannot be mobile, and I'm going to leave a lot of that information to Jorge to cover. I'm going to then put the final drill. I don't go to the final drill, and I do the last drill in OD mode. So I use cutting mode in the first 2 millimeter and 3 millimeter drills, but as I got to the wide implant that I want to place, I then went back into that septal bone and went in reverse mode. So you can see that you really have to fine tune and play with the drills. First cutting mode to get through the tooth, then when I remove the roots, I then go ahead and finish it and complete it with OD mode. Now I can put in a 6 millimeter implant, completely solid in that bone, and I leave just these little pieces of the root. I make sure I round them off, no sharp edges. And the next big question is the bone graft. Do we need to place a bone graft? Shouldn't we place a bone graft? I'm placing bone grafts in these areas, especially when they're significant. And then I'll cover it with a piece of fibrin. Fibrin's inserted. And I want to show you, again, I'm trying to show you some of the things that happen, because it's not always, even with I showed you a small complication with the Versa drills on an earlier case. People always ask me, well, what kind of complications have you had with socket shielding? And a very common one has been exposure of the shield. So here's, my hygienist, actually, you can see this picture was taken with intraoral camera. My hygienist calls me and says, you got to come in and see the patient. I think you left a root behind. I said, that's why we pay you the big bucks. So I walk in, she goes, what are you going to do? What do you think? I said, there's no infection here. Patient didn't even know it was there, but a hygienist found it. And I said, give me a burr, round diamond drill. And I just ground down the tooth and made sure it bled on the peripheral areas around the roots so that I can get epithelialization and closure. If it was an area that was down here where it was through the attached gingiva, you may want to place a connective tissue graft. But this is typical. I've had maybe 2 of these in all the cases that I've done over the last several years. I've had only 1 postoperative infection, and that's because the root that was kept in the socket was mobile, and I wasn't able to detect it. So these are the common issues that you may found with this type of pet therapies. This is after it heals. We go ahead, healing abutment, impression coping is placed, and now the patient is going to be finalized with his crown. And if we take a look at how this appears over time, you can see the pre-op, and this is now at about 6 months. Our ability to maintain the width of the socket, because if you maintain the roots, you preserve that socket wall, that labial plate does not resorb. And this is something that we continue to look at. So as my final case, what is the challenge? I think many of you say, I don't want to do that, or how much of it is it worth? Well, I think that there are 2 options. This is a gentleman who's a physician, comes in with 2 failing central incisors. One has a infection, apical abscess, so we're going to have to deal with this one differently. Whenever there's an infected root, pet therapy is not an option because the infection is obviously going to limit our ability to clean it out. So you only want to do this on teeth that are not infected. So here is an area where we're going to deal with it conventionally, and the other one we're going to attempt socket shield. So we take out the tooth, here's the granuloma, we do it as atraumatically as possible, a lot of different technologies to do that now. And we take a look at the 2 teeth. We place a little bit of collagen in the area, and now on the left central incisor, I'm going to perform a partial extraction therapy. I'm going to use my piezo. I'm going to use my PET kit. This is a really nice kit from Brasseler that we developed with them to be able to assist us in doing these cases atraumatically and with great precision. So I'm going to take out the palatal portion of the root on the left central incisor. I'm going to maintain the shield on that site on number 9. And this is the little shield that we use to protect the gingiva while we drill this down to bone level. We're going to round it off. And it's very important when we do this, and we'll talk about later, is to make sure that this root is always stable. If you ever see that there's mobility, you should remove it. If there's infection, I wouldn't pursue it. So on the left side, I'm going to use dual zone socket management. On the right side, we're going to use PET therapy. We're going to use a surgical guide using 360 imaging, and they do a very nice job. I'm able to place the implants exactly where I want, avoiding the shield. And you can see the two sites side by side. You never want the implant to engage that shield. You want to stay at least half a millimeter away. And now we know where the implant's going to be coming out in a good spot for a screw-retained restoration. So here's the shield, here's the bone between the shield and the implant, and we're able to get that accomplished. In the area where we're going to be doing a conventional approach, I'm sure that Salah has talked about his method of creating a slurry of bone and using reverse mode to pack the bone against the labial plate. That's something that I've used, certainly his technique, with allograft. So you take allograft small particles, and you then slowly use reverse mode, not on a high speed, but actually very, very low RPM, and you actually reverse mode and pack that bone against the labial wall. So we do that in the right central incisor. Left central incisor is the area where we're just going to pack it conventionally. So this area around the socket, we're just going to place some bone. I'm not really sure. We don't have the information yet with this technique of whether or not bone graft is helping or hindering the healing phase. But I like to place bone. It makes me feel better. Most dentists like to pack things with something. We did that here. So socket shield in this one, and of course in the other one, dual zone socket management. Temporary restoration is placed, and then early healing. Both of them heal very, very nicely. We take a look at this. We've maintained a nice scallop in the area. It was done atraumatically. Both were done immediately. One with an infected tooth with an apical fenestration. It was grafted internally, and the other one with socket shield. A few months later, I just do a little frenectomy using the laser. And then we take a look. And here you can see the little bit of remnants of that shield starting to peek through. But take a look at both sides. Very interesting. This is at 4 months. Patient comes back in. He's a physician. He still has the temporary on. This is at 6 months. So dual zone on this side, socket shield on this side at 6 months. I think we have to continue to evaluate this measurement between the two over time. I believe that what we will find is that with socket shield, you have a better preservation than you would around a conventional technique. And I think there's no doubt. And you'll see that beautifully presented by Jorge in the following presentation. Our dual zone paper that we published with Dennis Tarnow and Stephen Chu really looked at facial plate and palatal contour changes, peri-implant soft tissue thickness, and now third part of this study is going to be on gingival tissue discoloration. So 3 very, very big things that you need to evaluate with your cases, especially in the aesthetic zone. Are you finding that there is significant resorption, buccolingual ridge collapse? The peri-implant soft tissue, is it getting thinner? What you see in the cases now is that when the bone is lost, that labial plate resorbs, the tissue also gets thinner. So we're seeing that with some of these cases where we're using the root shield is that we're getting better tissue thickness. And of course, in terms of discoloration of the gingiva, with a shield, it obviously protects that. So we're taking a look at different concepts, and I think that that's one of the beautiful things about what we're continuing to do, is looking at tissue changes, that area above the head of the implant, and looking at the bone changes, that area on the labial plate. What does it mean, and how do we actually focus our techniques on this? If we really had to focus on most of these things, you'll see that these things are changing very rapidly. This is the study that was published only a few years ago We looked at 6 months to 4-year results, and even with dual zone management, we did have some minor collapse. Socket Shield was introduced to us back in 2010 by Marcus Herzler and Otto Zur. The whole concept behind being able to maintain that. You're about to see some beautiful histology on this concept by Jorge, and I look forward to it. And obviously this has progressed. There's been a lot of information now. Root membrane technique, 5 years post-loading, and they had no failures. This was a group from Greece that published this, and their ability to actually keep portion of the root, place their implants behind it, and after 46 cases followed it for 5 years with a 100% success rate of osseointegration. Howie and I published on the Pontic Shield. This was published in May of 2016, using the root shield technique, but packing bone behind it, not placing the implant. You're not obliged to place the implant the same day that you retain the root shield. You can do the root shield and pack bone behind it and create an ideal site for a Pontic or future implant. And this is something that we talked about in this article. Also, we talked about this, again, we just have this published later in the year, Partial Extraction Therapies Part 1. This was in the IJPRD, very prominent journal, and I'm certainly very proud of that. And in this journal, in this article, we provided 2 different tables of information about when we would use this technique, when we wouldn't use that technique. And Part 2, I believe, Howie's already been accepted for publication later in this year, where we'll talk about the techniques and how you actually do it step by step. So this is something that I really have had a great pleasure of being able to introduce to you. Partial extraction therapies, all these members of Dental XP in the forum really have allowed us to have a tremendously steep learning curve. I really owe it to all of you. And for those of you that have not engaged the site or the forum, I certainly welcome you. It's free, and we certainly love to have more people engaged with us. I thank you very much for the kindness of your attention.